Good morning. It's my great honor to be able to participate in this program. It began because I'm working with a doctor from Jeddah for 2 years. He has completed his OB/GYN in the United States and is doing now 2 years with me in general surgery and in minimally invasive gynecologic oncology. I have said to him the gift I'm going to give to him when he comes back is a eternal subscription to the New England Journal. I said it's the best. And in the New England Journal, as Dr. Abdul-Jabbar said, is the CPC, the Clinical Pathologic Conference. And as medical students at Harvard, we attended every week. And it was fairly dazzling because the problems were so complex and the speakers were so clear. I hope some of it was absorbed, I don't know, but it was a wonderful way of learning how you can teach from your experience and do it graciously and honorably. Then I was asked to speak about screening for ovarian cancer, and I turned to Nyala and I said, you know, what a mess, it's horrible, you know, it doesn't work. But the more I thought about it, I thought that there are some interesting things about this. And then in the other great journal in the United States, the New York Times, in the last 4 months there have been 3 or 4 very, very interesting articles about screening for ovarian cancer, ironically, and so I'm going to present those to you. So screening for ovarian cancer. The ovarian cancer is as I will say, is a very horrible disease. The Pulitzer Prize was won about 2 years ago by a Indian-born doctor who practices in the United States, and he wrote a book called The Emperor of All Maladies, the Biography of Cancer. And I would commend it to you if you're in the field. I would commend it to you anyway. It is so interesting. It is basically a philosophical book that says we haven't done very much. We've spent a lot of money, but we haven't done very much. In the book, they described the first case of cancer recorded in the world, and it was in Egypt in 2500 BC. And they describe a woman with a breast, and you touched it, and it was hard, and it was cold. And they said, the doctor said, there's nothing to do. So the question is, have we really progressed in the last 5,000 years? Among one of the more horrible diseases is ovarian cancer. It has been very recently described exactly as ovarian cancer. Before, in my country, people said, oh, my mother had stomach cancer, this, that, and the other thing. The initial therapy for this, of course, was surgery, and not many people survived. It was a horrible thing. I was doing a missionary work in Haiti. Haiti is a very poor country in the Caribbean. And a lady presented with ovarian cancer, and basically there was nothing we had to offer her because there was no chemotherapy or anything. Times have progressed. People have been looking for the cure. In 1972, the President of the United States declared a war on cancer. If you read the book Emperor of All Maladies, you will see, despite the publicity, the war goes on and very little has been done to change it dramatically. But people have recognized that if you find somebody with an early cancer, you can do much better to help them than if they present with a late cancer. If a patient in your area comes to you after the disease has progressed, you look at them and say, I'm so sorry, there's very little I can do. Whereas with the screening program in cervical cancer, Nasreen and Dr. Said are able to identify people with very early disease and do fairly radical surgery, but nevertheless a curative sort of a thing, so it can make an impact. So the issue is screening something that we can apply to ovarian cancer? My initial answer is no. So when we think of screening, everybody thinks it's diagnostic. You're going to go out and find somebody with a disease. If you're screening for goldfish and there's only one goldfish in the bowl, it's pretty easy. If you're looking for gold, you just follow the end of the rainbow. This is not screening. Screening is looking for something in the dark and not being able to see it. It's discovering America. It's looking for a star. It's trying to find gold in the waters of the rivers. Screening is a very, very, very difficult thing. Now, what difference can screening make? Does screening really change the lives of people? This is an example, I'll just point with my hand, of two patients with cancer. So these are two patients that developed cancer at this time. This patient has screening. And she just receives therapy and everything, and then she dies. This is the same patient who did not have screening. They find the cancer when she develops the symptoms, and she dies. So that the issue here is that it may be that with screening you detect cancers earlier, but that ultimately, sure, yeah, sure. Ultimately, no, I'm not hooked up. Ultimately, okay, got it. Ultimately, it may be the same. So the question really is screening going to make any difference? And it's unknown. We have very poor tools for screening for ovarian cancer. We have a physical examination. You can have a patient who presents with signs and symptoms. And then we have tests that are imaging tests, blood tests, and the point of the talk is going to be genetic testing. Physical examination has been the standby in gynecology since the beginning of time. You do a physical exam and you discover, thank you, I need a little, and you discover a mass. One of my colleagues, who is a very important epidemiologist in the United States, wrote an article, and again in the New York Times, that said that the bimanual examination of a woman is an unnecessary procedure. And for most of us, it was totally astonishing. We'd never really even thought about it. What they said was that when you do the examination, you really are looking for asymptomatic disease. It says, first of all, you don't find it. But it says, second of all, you find a lot of other things. And it causes surgery, it causes this, that, and the other thing. It says, it really is causing more problems than it solves. It also said, and we were discussing this last night about doing pap smears in this screening sort of a situation. It's very difficult if you want women to participate, if you put a big screen up that says cancer screening, what woman's going to walk in and say, oh yes, in front of everybody. But some of these tests can be done at home. You can give the woman a kit. She does the testing in privacy. A health nurse comes through the community, picks it up. You can do pap smears. You can do sexually transmitted diseases. You can do everything. So you don't need to do an examination. We were talking about, people have talked about making a van that goes around from community to community. Excuse me. Again, my perception in a conservative community is that's going to go very poorly. No one's going to come to it. But if a nurse comes around to the town and there are 10 homes, and she distributes the test, and the next day she comes back and she gets 8. The next day she goes and she gets the other 2. And so you have 100%. And this has been shown in many countries to be very, very acceptable. So the thing of the pelvic examination is, for detection of ovarian cancer, is a fallacy. When someone gets the signs or the symptoms are bloating, I can't eat, my clothes don't fit. Unfortunately, when a woman presents with this, she has advanced disease. And seen from above, you may say, you know, there's really very little I can do for this woman. We do a lot, but we may not change what actually is going to happen to her. So we look to testing. What tests can we do to do early detection of ovarian cancer? Sorry. And there's imaging, and everyone, you know, you have an ultrasound, you have all of these other sorts of things. Just to cut through the baloney, ultrasound has been the one that seems to be the best for detection of pelvic disease in an isolated way. There are blood markers. I'm certain you've heard of every one of these, and they keep, tomorrow there will be another one and another one. I have been involved in this one, Ovacheck. It was data done in Britain, and not one bit of it could be reproduced any other place in the world, and they were selling it to everybody. It was beware. Now, I'm going to come to genetic testing, and these are the newer things that are coming forward, and I see this as it may have very little applicability to ovarian cancer. I think it has much more, but it actually has, in my opinion, limitless possibilities. People have looked at taking the tests, whether they're imaging tests or blood tests, and combining them. They said, oh, if I just do ultrasound, that doesn't work. If I just do the CA-125, it doesn't work. Let's put them together. And that's been what many, many people have been doing. But if the goal of the screening test is to achieve an early diagnosis and therefore a better cure, it should decrease mortality. There are 3 very current studies in the world, one from Japan, one from the UK, and one from the United States, looking at putting these 2 methodologies of ultrasound and blood testing together. They have shown some earlier detection. They have shown no change in the mortality of the disease. The changes that they've shown have all been statistically non-significant. The last test, though, or study is very, very interesting because they're looking at people with ovarian cancer, or possible ovarian cancer, I'm sorry. And you do a blood test like the CA-125. So do you look at the number? You know, it's 24. Well, but our lab 24 is normal because it's 35 is but on our lab, the other lab, 20 is. So that one number is very hard to interpret. So what they have said is if you will pick a woman whom you consider to be at high risk for ovarian cancer and do serial blood testing, just watch and see if you see it make a small inflection up, not abnormal, just up. And it's called WOCA. And in doing this, they believe that they're going to be able to show this. Nevertheless, this whole thing of doing screening is a bit of a will of the wisp. The blood tests are all tumor-associated antigens. They're not actually markers for the tumor. Ovarian or CA-125 can be elevated in appendicitis, in diverticulitis, and in pneumonia. It can be elevated in fibroid tumors, benign cystic teratomas. It's not specific. It is a tumor-associated antigen. The other new The other new blood tests have been approved for use in the United States, not for screening, but for monitoring or doing more discriminatory testing. The irony is that they have shown no effect in screening, and they are just expensive. I'm sorry. So we come to genetic tests. And genetic tests are something that we know something about, but for ovarian cancer, people are now using this to screen for early disease and to prevent any disease or new disease. So that we've discussed this before. If I had $100, real, whatever, and I was going to put it on cure or prevention. You put it on cure, you're going to come back and say, I need another $100, it's not working. You put it on prevention, and you may well stop the problem. So that I think that prevention or early detection are very, very important. A universal truth is that cancer is caused by a genetic mutation. You're not born with cancer. You're born with basically a normal genetic structure. You have tumor suppressor genes, so that if you get a pre-cancer, it can tamp it down. The BRCA1 and 2 are tumor suppressor genes. If you get rid of them, then people develop cancers because you can't suppress them. Now, while all cancer is genetic, not all cancer is hereditary. So sometimes you say genes, oh, that means it's in my family. That's not necessarily true. Currently, probably about 10 to 15% of cancers can now be shown to be directly caused by a genetic mutation that is inheritable. In other words, if your mother had it, you have a 50% chance of having it. If you have it, your children have a 50% chance of having it. At the same time, we note that there are a large number of families in which cancer runs through the family, and they can gene test them until the end of time, and they don't find it. I suspect that we will find the gene in these people, and so that the number grows from 15 to 20 to 25. It's important to know this because if you want to target somebody who is at risk for disease, if you can find out their genetic makeup, then you may have a very good chance to do that. Here begins the really weird stuff. At Johns Hopkins in January, they reported detecting ovarian and uterine cancer by doing pap smears. Now, that is so counterintuitive that you can't even think of it. So it's interesting because in many parts of the world they do pap smears all the time, and if you just included this genetic test in the study, you may change things a great deal. So what they did is they looked at patients who had uterine and ovarian cancer, and they took the tumors out, or the tumors had come out, and they looked for a panel of genes in the people with endometrial and with ovarian cancers, and they confirmed these. And then they did the pap smears, or had done the pap smears, and they found the same tumor protein in 100% of the patients with endometrial cancer. Now, they only found it in 40% of ovarian cancer, but if you are taking a board examination and they say pap smear will disclose uterine cancer in what percent? Well, the answer may be 40, 30, 20, something like that. It's not a good screening test, but it would appear that this genetic test may be a very good test for screening people with uterine cancer. I guess the question is, will it get pre-cancer or early cancer? We don't know. But a pap smear. Also, there are tests coming out now, this is not gynecology, but it is genetics, of examining stool samples. And you can examine stool samples and do the DNA, and you can diagnose the cancer. The problems are that the gold standard for this is colonoscopy, and the Hemoccult, the blood test for the stool, is very cheap and very easy to do. In our country, the incidence of colon cancer is probably about the same, but it is decreased. The incidence of advanced colon cancer is infinitesimally small because everybody gets a colonoscopy, and you find it at an earlier stage. So this is what we're talking about, the genes. We're talking specifically about in the female, but the BRCA1, the 13 and the 17 are inherited both by men and women. So that when you're looking at genetics, you want to look at both the mother and the father. The goal of the screening is to provide basically prevention of the disease. You want to prevent the gene mutations. Now that's a kind of an odd sort of thing to do. You can give chemicals to block it. You can do surgery. But by far the most important thing, I think, is to define the hereditary characteristic. You can change where you live. You can change what you expose yourself to. You can change who you live around. You can do all of these sorts of things, but it ends up leaving you in a very isolated part of the world, whether it's Scandinavia or the top of some mountain. The last study that was presented approximately a month ago was looking at, and this is a kind of a weird slide, but I'll show you, people with breast cancer, colon, endometrial, ovarian. And what they said was that for years people have looked at the genetic structure of leukemias because it's blood. Everybody can look at it, and they have all of that signature. And there's a young man at Memorial Sloan Kettering that started looking at endometrial cancers. And so what they found with acute myeloid leukemia was you could stratify patients. You could say, this patient, easy to cure. This patient, difficult. This patient, we'll never cure. So they don't use these sorts of treatments. For uterine cancer, we have the standard endometrioid adenocarcinoma, very easy to treat. But the papillary serous tumor of the endometrium is ovarian cancer in our experience. The irony is that when they looked at the gene structure from these cancers, and these, they were similar. So from a treatment point of view, it may end up that rather than treating ovarian cancer, you're going to start to treat people with a certain gene defect, because that's the commonality of the disease. I love this slide. So the point of this slide is to say that from that article I started drawing associations, and the point is that in lung cancers they can stratify and find people whom they can't treat. They can do that in leukemia. We can do it in endometrial cancer, but at the same time we find out that the relationships are all mixed up. So that we really are now looking at the diseases as a genetic disease and not necessarily a site disease. So I think that for the outlook of patients in the future with ovarian cancer, I believe that things are going to get much brighter. I think that we're going to be able to discover the disease earlier. We're going to be able to identify people who are at high risk, and we're going to be able to say women with certain gene types are not going to do well with any sort of a treatment. I'm sorry, I looked at this and I said, is that a sunset or a sunrise? I didn't know. So I did a cartoon drawing, because that's clearly a sunrise. So as a conclusion, I think that for patients concerned about ovarian cancer, if you can find out whether they have a genetic predisposition, you can do an intervention and prevent them from having breast ovarian cancer. It's wonderful. For treatment, you can diagnose them by genetic disease and not just by site disease. And so I think that perhaps the challenge for Dr. Sate is going to be to look at the patients in the area and find out what is the genetic risk for them. For women, it's basically BRCA1 and 2 and the HNPCC Lynch 2 syndrome, colon. Now, Niall, Dr. Helmy, all of these tests are done with blood tests. And so you have to get patients in, you draw the blood. So the same company that does the blood test now does it with swish and swallow. You just take some water, buccal cells, and spit. We call it the spit test. So Niall has now taken every woman that comes to our office and does the spit test. And it's very interesting because, I'm a GYN oncologist. I should know about all this stuff. People start popping up that you didn't know about. Again, this is a very simple test to administer. Unfortunately, it's very expensive, but that's a negotiation. So, thank you. I apologize.